Hello everyone, welcome at SudhirEyeCoach, a channel for budding and emerging ophthalmologists. I am Dr. Sudhir Srivastava, Cataract and Refractive Surgeon, Head of Sanai Group of Eye Hospitals at Lucknow. Today I'll be sharing a video of cataract surgery performed in a 5-year-old child where phacoemulsification was done and a toric intraocular lens was implanted. Pediatric cataract surgery is entirely different from adult cases and demands meticulous planning, precise execution, and special attention to long-term outcomes. In this video, I'll be highlighting a few important practical tips and key points while dealing with such pediatric cases, which I believe will be helpful for young ophthalmologists and surgeons undergoing phacotraining. The surgery was performed under general anesthesia and special care was taken to ensure that the anesthesia technique did not cause a rise in intraocular pressure. This is very important and often overlooked aspect in pediatric case. And because as raised intraocular pressure can significantly affect the surgical outcome and especially during the formation of capsular access. One of the most important steps is in a pediatric case is the formation of capsular access. The pediatric anterior capsule is extremely elastic and has a strong tendency to run towards the periphery. Therefore, while initiating and continuing the access, it is very important to apply traction towards the center at all time. And in this case, I stained the anticapsule for the better visualization. Even though the red reflex was reasonably good, staining of a capsule should not be skipped in pediatric cases as it provides better control and reduces the risk of an uncontrolled peripheral extension. The rest phaco procedure is relatively straightforward because there is no formed nucleus. Therefore, I directly proceeded with irrigation and aspiration, and gentle hydro procedure were performed to separate and loosen the cortical matter within the capsular bag, which significantly facilitates easy and safe cortical aspiration. After completing cortical cleanup, the next important decision is whether primary posterior capsulotomy (PCC) or posterior capsular access is required or not. In this case, child was around 5 years of age and was expected to cooperate well for a YAG capsulotomy in the post-operative period if required. So additionally, since a toric intraocular lens was planned for the implantation, I decided not to perform a capsular access posterior capsular access. Therefore, posterior capsule was left intact in this case. In pediatric cataract surgery, the preferred choice of intraocular lens is usually a monofocal or an advanced monofocal lens with or without toric correction. In this case, I implanted a hydrophobic single piece toric intraocular lens and aligned it precisely as per the planned access. So just to summarize a few important tips in the pediatric cataract surgery, first is the anesthesia. It should be well planned and ideally performed under general anesthesia, ensuring there is no rise of intraocular pressure. Then the capsular access is a critical step. Always stain the anticapsule and remember that the pediatric capsule is very elastic, and while performing capsular access, always apply traction towards the center. And since there is no formed nucleus in the pediatric case, only irrigation aspiration is required and there is no need for nucleus aspiration or ultrasonic energy. The decision to perform a primary posterior capsular access or capsulotomy depends on the child's age and the surgeon's preference. When indicated, it should be combined with the anterior vitrectomy, and the preferred intraocular lens in the pediatric case is hydrophobic single piece monofocal or advanced monofocal lenses with or without toric corrections when required. So just enjoy the steps, and if you have any comment, please do so. And if you have not subscribed the channel, please subscribe the channel, and thanks for watching.